Hello and welcome to the lecture on acute kidney injury and chronic kidney disease. I hope you're having a great day. This is Professor Osorio. Here's a little humor to start us off. Hello, kidney. The main functions of the kidneys are to control the volume and composition of extracellular fluid, remove waste products from the body, regulate blood pressure through the release of renin, stimulate red blood cell production, convert vitamin D into its active form, and maintain the body's acid-base balance. This slide outlines the key functions of the kidneys in maintaining homeostasis by using the mnemonic a wet bed. Let's look at the regulation of fluid volume and osmolality in the kidneys. The kidneys receive 20 to 25% of cardiac output with a GFR of around 120 to 140 milliliters per minute. Renal blood flow remains stable through autoregulation and hormonal control as long as the mean arterial pressure is 70 millimeters of mercury or higher. Water is reabsorbed in the proximal convoluted tubules based on solute concentration. Remember that osmolality is when sodium, chloride, calcium, glucose, amino acids, and bicarbonate are reabsorbed in various sections of the nephron, particularly in the proximal convoluted tubule, the loop of Henle, and the distal convoluted tubule following filtration. The process of sodium and water reabsorption in the kidneys involves reabsorption which occurs in both the proximal and distal tubules of the nephron. In homeostasis and under normal conditions, the amount of sodium and water excreted is equal to the amount ingested, helping the body maintain normal values. Sodium excretion is controlled by aldosterone. When aldosterone levels are high, sodium is reabsorbed more effectively, and water follows this reabsorption. The renin-angiotensin-aldosterone system is activated in response to decreased renal perfusion or low sodium concentration, playing a critical role in fluid and electrolyte balance. And know your normal electrolyte values based on the book. The effect of renal dysfunction on electrolyte values is that sodium may be low or you might be hyponatremic due to impaired reabsorption or high hypernatremic if there is excessive loss of water relative to sodium. Your potassium usually increases, puts you at a state of hyperkalemia due to reduced renal excretion, which can lead to cardiac arrhythmias. Calcium often decreases, or hypocalcemia, because the kidneys are less able to activate vitamin D, which is necessary for calcium absorption. Phosphate increases, hyperphosphatemia, due to the kidney's reduced ability to excrete phosphate. Magnesium increases as well, hypermagnesemia, as the kidneys lose the ability to excrete excess magnesium. Chloride imbalances may occur, contributing to acid-base disturbances such as metabolic acidosis. The kidneys help maintain a blood pH of 7.34 to 7.45. They also reabsorb bicarbonate from the filtrate and return it to the bloodstream. The new bicarbonate is generated in tubular cells. Your acids or your hydrogen protons are excreted directly or indirectly by binding to buffers like phosphate and ammonia. The normal ratio of bicarbonate to carbonic acid is 20 to 1. The kidney's role is to conserve bicarbonate and excrete hydrogen ions. This is relatively slow process compared to respiratory compensation. Bicarbonate is naturally produced when carbon dioxide reacts with water, forming carbonic acid, which then dissociates into hydrogen ions and bicarbonate. Overall, this process helps maintain the body's acid-base balance over a longer period. Now I want to explain the role of the kidneys in erythropoietin production and its impact on anemia. The kidneys produce and release erythropoietin in response to decreased oxygen levels in the renal blood supply, often due to a reduction in red blood cells. Erythropoietin then stimulates the bone marrow to produce more red blood cells to increase the blood's oxygen carrying capacity. In cases of renal failure, the kidneys may not produce adequate erythropoietin, leading to anemia due to a decreased production of red blood cells. The kidneys convert vitamin D into its active form, which is crucial for calcium absorption and bone health. The kidneys produce prostaglandins, which have a vasodilatory effect, helping to maintain proper renal blood flow. Urea is a byproduct of protein metabolism. So if urea is not excreted, it can accumulate in the blood, leading to toxic effects known as uremia, which we'll talk about later. The kidneys play a key role in eliminating drug byproducts from the body. Creatinine, phosphates, sulfates are all metabolic waste products filtered and excreted by the kidneys. If the kidneys are not functioning properly, these substances can build up in the body, resulting in various complications. Blood urea nitrogen is important in assessing renal function. The BUN levels typically range from 7 to 18 milligrams per deciliter. BUN is a nitrogenous waste product resulting from protein metabolism. Your BUN alone is not a reliable indicator of renal function. Its relevance is best assessed when evaluated alongside creatinine levels. BUN can increase for non-renal reasons, such as increased protein metabolism. These are for people that consume a high protein diet. And in cases of muscle breakdown due to trauma or from intense exercise. Creatinine is a more reliable indicator of renal function compared to blood urea nitrogen. It is a waste product generated from muscle energy metabolism. The typical creatinine range is zero point 0.6 to 1.2 milligrams per deciliter. While not as accurate as a GFR or glomerular filtration rate, creatinine levels provide insight into kidney health. If you have a creatinine level that's 2 times the normal level, that indicates approximately 50% kidney damage. If you have 8 times the normal level, that's about 75% kidney damage, and 10 times the normal level suggests around 90% kidney damage. Please note that severe muscular diseases can significantly increase creatinine levels, making it less reliable as a sole indicator of kidney function in these cases. The glomerular filtration rate measures the amount of blood filtered by the glomeruli in the kidneys each minute. In laboratory results, it is typically reported as the eGFR, or estimated glomerular filtration rate. A normal eGFR is usually reported as greater than 60 milliliters per minute, though the textbook normal value is 125 milliliters per minute, so take a note of that. This measurement is crucial in assessing kidney function and will play an important role when evaluating the stages of kidney disease. In everyday clinical practice, eGFR using serum creatinine is widely used because it provides a good approximation of kidney function. Despite some limitations like reliance on creatinine, which can be affected by factors like muscle mass, it is valuable and non-invasive tool for evaluating renal health. In summary, while creatinine is a simple and accessible marker for kidney function, GFR, particularly eGFR, provides a more accurate and comprehensive assessment. The true gold standard for kidney function measurement is a directly measured GFR, but due to practical limitations, eGFR using serum creatinine is commonly utilized. As mentioned before, creatinine is a waste product formed from the normal breakdown of muscle tissue. It is filtered by the kidneys and excreted in urine. The level of creatinine in the blood is used to assess kidney function. High blood creatinine levels can indicate impaired kidney functions or kidney disease as the kidneys are not filtering it out efficiently. And as a review, creatinine levels can be influenced by factors such as muscle mass, age, gender, diet, and hydration, which means it is not always an accurate reflection of kidney function in its own. Creatinine clearance is an important measure of kidney function. It's used to detect and evaluate the progression of renal disease. It also reflects the volume of blood cleared of creatinine in 1 minute, providing an approximation of the GFR. Typically involves a 24-hour urine collection to accurately measure creatinine levels. Creatinine clearance gradually decreases with age, affecting normal values. For normal values, refer to Table 53.5 on your book. Renal failure occurs when the kidneys can no longer adequately remove the body's waste products or perform their homeostatic and regulatory function. We're going to look at acute kidney injury first, then chronic kidney disease. Acute kidney injury, sometimes referred to as acute renal failure, has a sudden onset. It's characterized by a rapid loss of kidney function. The most common cause of AKI is acute tubular necrosis. It's identified by a decrease in urine output and/or an increase in creatinine levels. AKI is potentially reversible if promptly recognized and treated. Mortal- Mortality rate is high, ranging from 40% to 90%. Death is often due to underlying cause of AKI, such as sepsis. AKI develops suddenly within hours to days. There is an abrupt decrease in GFR. It leads to an accumulation of nitrogenous waste, such as BUN and creatinine, defined by a 50% or greater rise in serum creatinine above baseline levels. AKI is seen in about 5% of all hospital admissions. Approximately 60% of ICU patients develop AKI. High mortality rates in the ICU setting ranging from 70 to 80%. AKI is an independent risk factor for death, increasing the risk fivefold. Despite its severity, AKI is often a reversible condition if treated promptly and appropriately. Traditional GFR estimation equations included a race coefficient for African Americans. This was initially based on studies that observed higher average creatinine levels in African American populations. However, the use of race-based adjustments in GFR equations has become controversial. Many healthcare professionals and institutions are now moving away from race-based adjustments to avoid potential biases in assessing kidney health. In essence, GFR adjustments for African Americans were historically made to better reflect differences in muscle mass and metabolism. However, the medical community is increasingly advocating for more individualized approaches that do not rely on race, focusing instead on more accurate measures like direct GFR measurements. The typical presentation of AKI primarily impacts the kidney's ability to maintain homeostasis, leading to a disruption in electrolyte levels such as sodium, potassium, calcium, and issues with fluid balance, potentially leading to edema or dehydration. Difficulties in maintaining stable blood pressure due to impaired fluid and electrolyte regulation as well. Now, endocrine functions such as erythropoietin production and vitamin D metabolism are affected less because they require more time to show those changes. The size of the kidneys typically remain preserved during AKI, unlike in chronic kidney disease, where kidneys may shrink over time. AKI is often accompanied by signs of an acute health event, which can include reduced blood flow, such as in cases of hypotension or shock, direct injury, which is when there is physical damage or toxicity directly affecting the kidneys, obstruction or blockages in the urinary tract that impede the flow of urine. The causes of AKI can be broken down into three categories: pre-renal, intrarenal, and post-renal. Pre-renal is caused by factors external to the kidneys that lead to decreased blood flow to the kidneys, affecting perfusion and filtration. It's characterized by the kidney itself remaining intact but receives inadequate blood supply. Some causes to consider are loss of circulating volume, conditions like shock, hemorrhage, excessive diuresis, vomiting, and diarrhea; impaired cardiac function, such as in myocardial infarction, heart failure, cardiogenic shock; vasodilation, in the cases of anaphylaxis, sepsis, and the use of antihypertensives; and if there is an obstruction or reduced blood flow due to these various obstructions leading to the kidneys. Intrarenal is caused by damage to the nephron itself, which can result from prolonged pre-renal conditions leading to direct kidney injury. It's characterized by damage to kidney structures such as the glomeruli and tubules. Some causes consider glomerulonephritis, or an inflammation of the glomeruli, acute tubular necrosis, ATN. It can be ischemic due to the lack of blood flow, or nephrotoxic. Let me say that again. Nephrotoxic due to toxins like gentamicin, aminoglycosides, and contrast dyes. Myoglobinuria could also cause intrarenal kidney injury. It's due to muscle breakdown products entering the kidneys, and those are too big to be filtered by the kidneys. Nephrotoxins, drugs and substances that are toxic to the kidneys; and hemolytic blood transfusion, which is a complication from massive blood transfusions. Crush injuries and infections can also suffer intrarenal kidney injury because of the physical trauma or severe infections caused to the kidney. Post-renal causes are caused by disruptions of urine flow due to obstructions after the kidneys. It's characterized by causes such as renal calculi or kidney stones. They cause blockages within the urinary tract, blood clots obstructing urine flow, BPH or benign prostatic hyperplasia, the enlarged prostate blocking the urethra, urethral strictures and tumors, narrowing of the urethra, or tumors causing obstructions. The postrenal causes are almost always treatable if identified early. In acute tubular necrosis, there is severe kidney ischemia causing a disruption in the basement membrane and patchy destruction of the tubular epithelium. Nephrotoxic agents cause necrosis of tubular epithelial cells, which slough off and plug the tubules. ATN is potentially reversible if the basement membrane is not destroyed and the tubular epithelium regenerates. ATN is the most common cause of AKI for hospitalized patients. Risks associated with development of ATN while in the hospital include major surgery, shock, sepsis, blood transfusion reaction, muscle injury from trauma, prolonged hypotension, and nephrotoxic agents. Contrast-induced nephropathy, or CIN, is another cause of AKI. Approximately 1 million contrast studies are performed each year. Around 15% of patients undergoing these procedures may develop CIN, and of those 15%, 1% may require dialysis. CNI is potentially preventable with appropriate measures. Patients with a creatinine level greater than 2 are considered at high risk for CIN, so talk to your doctors before taking that patient to a CT with contrast. Hydrating the patient before the procedure is the most effective method to prevent CIN. Also, remember that acetylcysteine and bicarbonate are substances that have a protective effect on the kidneys and can help reduce the risk of developing CIN. Let's talk about the manifestations of AKI and the nursing management that go along with them. AKI manifests in different phases. In the initiation phase, the initial insult or injury occurs, leading to the onset of symptoms. The oliguric phase is marked by a decreased ability to excrete waste products, resulting in reduced urine output. Once in the diuresis phase, there is a gradual increase in urine output as the kidneys begin to recover. Lastly, in the recovery phase, renal function either improves, stabilizes, or fails to recover fully, determining the patient's outcome. Notable urinary changes in the oliguric phase of AKI are the following. We know that oliguria is defined as urine output of less than 400 ml per day, which is the minimum required to eliminate waste products. Most common, most common clinical manifestation of AKI typically occurs within 1 to 7 days of kidney injury and may last from days to months. Not all patients exhibit oliguria. Approximately 50% may have adequate urine output. In the oliguric phase, urinalysis may reveal cellular debris, which indicates damage to the kidney tubules. The presence of RBCs or red blood cells suggests potential damage to the glomeruli or kidney structure. And white blood cells in the urine indicate inflammation or infection in the urinary tract. Often 300 milliosmoles per kilogram or higher of urine osmolality indicates impaired kidney concentration ability. Some patients may have normal urine output, but still fail to filter out waste products adequately. This is known as non-oliguric phase. During the oliguric phase in AKI, you want to watch for hypocalcemia as it worsens AKI. Addressing hypovolemia through fluid replacement can help reverse pre-renal causes. Also, keep an eye for fluid retention. As urine output decreases, fluid begins to accumulate in the body, potentially leading to fluid overload, resulting in conditions such as heart failure, pulmonary edema, and pleural effusions. Also, watch out for metabolic acidosis. The kidneys lose the ability to metabolize ammonia, which is crucial for neutralizing acids in the body, leading to an accumulation of acid products in the blood. The kidneys also struggle with reabsorbing and regenerating bicarbonate, which then worsens acidosis. During the oliguric phase, you also want to watch for sodium balance, as the intrarenal causes can damage the renal tubules and impair their ability to conserve sodium. Hyponatremia results from the kidney's inability to retain sodium, leading to a dilutional effect in the body. Also watch for potassium excess. The reduced ability of the kidneys to excrete potassium results in hyperkalemia. The exacerbated acidosis further worsens hyperkalemia as hydrogen ions enter cells, causing potassium to move out into the bloodstream. Hyperkalemia can lead to dangerous dysrhythmias, necessitating close monitoring of cardiac function. Other considerations are that you have to look at hematologic manifestations. The causes are related to both the underlying disease and the effects of kidney dysfunction. Anemia results from reduced production of erythropoietin by the kidneys, which is necessary for red blood cell production. Waste products accumulate, so look at your BUN levels as they increase, though they may be influenced by factors other than kidney function, making them less reliable. More reliable than BUN, you want to look at creatinine, as it is not affected by other factors, indicating the extent of waste product accumulation. Neurological changes can also be noted, so accumulation of waste products in the blood can lead to various neurological symptoms, such as confusion, lethargy, or even seizures in severe cases. The key points to remember in the diuretic phase is that it is initiated when the underlying cause of AKI is corrected. There is a gradual increase in urine output ranging from 1 to 3 liters per day and potentially up to 5 liters per day. The glomerular filtration is starting to recover, but the nephrons are not yet fully functional. Urine output is due to osmotic diuresis. The kidneys can excrete waste products but still lack the ability to concentrate the urine. This phase can lead to hypovolemia and hypotension, requiring careful monitoring. Patients are at risk for hyponatremia and hypokalemia and other electrolyte imbalances. The diuretic phase may last for 1 to 3 weeks. In the recovery phase of AKI, you'll see a gradual increase in your GFR. BUN and creatinine levels begin to normalize. However, kidney function stabilization can take up to a year, leading to possible long-term effects such as 1 to 3% decrease in GFR. Some patients may not fully recover, potentially remaining oliguric or anuric, progressing to chronic kidney failure. Diagnostic studies for diagnosing AKI and to establish the treatments include getting a UA for the purposes of looking at cells or casts, sediments, if there's any blood in the urine, getting a renal ultrasound to look for any obstruction, getting a renal scan to establish that there is adequate blood flow to the kidneys, as well as that the tubules are functioning well and that the collecting system is intact, looking at MRIs and CT scans to see any lesions or masses, obstructions, or if there are any vascular problems leading to the kidney, and intrarenal specific causes for kidney disease might require a renal biopsy, and of course, look at your blood work, such as a renal panel or a CBC. On the horizon, there are now early predictive biomarkers that can predict kidney disease before a patient loses up to 50% of renal function. These biomarkers can predict and identify AKI earlier before creatinine starts to rise, much like cardiac biomarkers we use for the diagnosis of MI. To properly manage AKI, you want to treat the underlying cause. For pre-renal, you want to address issues with blood flow to the kidneys, such as dehydration or heart failure or shock. For intrarenal, you want to manage direct kidney damage, like acute tubular necrosis, nephrotoxicity, or glomerulonephritis. For post-renal, you want to relieve obstructions in the urinary tract, such as stones, tumors, or strictures. Maintaining fluid balance by monitoring daily weights to assess fluid status and adjust fluids accordingly helps prevent both overload and dehydration. You also want to monitor electrolytes. By regularly checking electrolyte levels such as potassium and sodium, you can take corrective actions as needed to maintain homeostasis. You want to adjust medication dosages that are cleared by the kidneys to prevent accumulation and toxicity. And you also want to monitor and correct acid-base disturbances, often using bicarbonate if necessary. Initiate dialysis in severe cases to support kidney function and manage waste and fluid removal. You also want to provide treatment to alleviate symptoms and prevent complications related to AKI. Collaborative care in AKI include addressing nutrition. Nutrition should be tailored to the underlying causes of AKI. You want to implement a low protein, high carbohydrate diet to reduce kidney workload and restrict potassium rich foods to manage hyperkalemia. You want to administer calcium supplements or phosphate binders as needed to maintain electrolyte balance. And sometimes you might need to implement continuous renal replacement therapy or CRRT for patients with severe kidney failure and fluid overload. We'll talk about this later. You want to administer erythropoietin if indicated, particularly in cases of anemia due to decreased erythropoietin production. And you want to prevent complications by monitoring for and managing potential complications such as electrolyte imbalances, fluid overload, and infection. In acute renal failure, you run the risk for developing hyperkalemia due to impaired potassium excretion by the kidneys, leading to cardiac arrhythmias. Hypermagnesemia, due to the accumulation of magnesium caused by decreased renal excretion, and hyperphosphatemia, due to elevated phosphate levels result from the kidney's inability to excrete phosphate efficiently. So those are the three things that go up: potassium, magnesium, and phosphorus. And then the two things that go down are calcium and sodium. Hypocalcemia is due to the decreased calcium absorption in the GI tract due to low vitamin D activation by the kidneys. Remember, calcium release needs vitamin D activation. And this leads to symptoms like tetany. Hyponatremia is caused by the kidney's inability to conserve sodium chloride, potentially leading to cerebral edema and altered levels of consciousness. Proper management of these electrolyte imbalances is crucial to preventing further complications and improving patient outcomes in acute renal failure. Let's discuss management strategies for hyperkalemia, especially in the context of acute kidney injury. Know that regular insulin IV helps move potassium from the bloodstream into the cells, lowering serum potassium levels. Sodium bicarbonate temporarily shifts potassium into the cells by correcting acidosis. Calcium gluconate IV protects the heart by stabilizing the cardiac cell membrane, reducing the risk of arrhythmias. Dialysis is used when hyperkalemia is critically high or the patient is hemodynamically unstable, effectively removing excess potassium. Sodium polystyrene sulfonate or K-oxalate is a medication that exchanges sodium for potassium in the intestines, promoting potassium excretion. You want to encourage dietary restrictions by limiting foods high in potassium to prevent further elevation of serum levels. Each of these interventions addresses hyperkalemia by either moving potassium into cells, removing it from the body, or stabilizing cardiac function. A renal diet is designed to support kidney function and slow the progression of kidney disease. It primarily focuses on limiting specific nutrients that can build up in the body when kidney function is impaired. Here is a breakdown of the components of a renal diet. It has to be low sodium because excess sodium can cause high blood pressure and fluid retention, which can further strain the kidneys. Want to aim for less than 2,300 milligrams of sodium per day. In order to do that, you want to avoid processed foods, canned soups, fast foods, salty snacks, and use herbs or sodium-free spices for flavoring. The kidneys process protein waste as well, so excess protein can increase the burden on the kidneys. Intake for protein vary depending on the stage of kidney disease and the individual's needs. Typically, patients with chronic kidney disease are advised to have lower protein intake, while those on dialysis may need higher amounts of protein because of the demands on the body when patient is on dialysis. So you want to advise your patient to choose high quality protein sources such as lean meats, fish, eggs, and small amounts of dairy. Plant-based proteins like beans and tofu are also options, but should be portion controlled. You want to advise your patient to limit their potassium intake. The kidneys regulate potassium levels, but impaired kidney function can lead to hyperkalemia, which can affect the heart's function. So especially when their blood potassium levels are already elevated, you want to tell them to limit intake of foods such as bananas, oranges, potatoes, tomatoes, spinach, avocado, dried fruits, beans, and nuts. A better alternative would be apples, berries, grapes, cabbage, cauliflower, white rice, and pasta. You also want to tell them that the kidneys remove excess phosphorus. So high phosphorus levels can weaken bones and damage blood vessels. And when you already have kidney disease, this problem can be exacerbated. So you want to advise your patient to limit dairy products, nuts, seeds, chocolate, colas, whole grains, and processed foods containing phosphate additives. A good alternative would be the use of non-dairy creamers, rice milk, ones that are not enriched with phosphorus, of course, and avoid processed foods with phosphorus additives. In advanced kidney disease, the kidneys cannot remove excess fluid efficiently, which can lead to fluid overload. Fluid restrictions are individualized based on urine output and kidney function. Patients on dialysis often need stricter fluid limits. You want to monitor and measure daily fluid intake, include fluids from soups, ice, and gelatin. You want to encourage your patients to use small cups, chew ice, and suck on sour candies to help reduce thirst. Very importantly, you also want to advise your patients to consume adequate amounts of calories. Maintaining energy and a healthy weight is crucial, especially with dietary restrictions. You want to include adequate calories from carbohydrates and fats. If protein intake is restricted, calories from other sources are needed. Good sources for adequate calories are healthy oils like olive oil and include permitted fruits. Also, you want to encourage your patients to consume grains and sugars in moderation. A sample renal-friendly food menu would include fruits such as apples, berries, grapes, cherries, pineapples, vegetables such as cauliflower, cabbage, bell peppers, green beans, cucumbers, and zucchini. Proteins from sources like lean meats, chicken and turkey, fish, eggs in moderation, and tofu in moderation. Grains, good sources would be white bread, white rice, pasta, and tortillas. You want to advise your patients to just generally always look for no added salt, low sodium, or no salt added on food packaging. You want to use fresh ingredients. Fresh foods contain less sodium, less potassium, and less phosphorus than processed foods. And if they can, work with a dietitian. Most kidney clinics have a dietitian specializing in kidney disease because they can help customize a diet plan to help individual needs, preferences, and medical requirements. This diet is typically adjusted based on the stage of kidney disease, lab values, and treatment, especially if your patient's on dialysis. So you want to always consult a healthcare provider or dietitian for a personalized renal diet plan. Now let's shift our focus to discuss chronic kidney disease and end-stage kidney disease. This slide provides an overview of chronic kidney disease, which is also referred to as chronic renal failure. CKD is characterized by a gradual, often subtle onset and can eventually progress to end-stage kidney disease. The diagnostic criteria for CKD include a GFR of less than 60 for at least 3 months and/or evidence of kidney damage persisting for more than 3 months. The damage incurred is typically permanent. The mortality rate for patients on dialysis ranges from 19% to 24%, with cardiovascular disease being the leading cause of death. 20 million Americans have kidney disease, 1 in 9 adults. Another 20 million are at risk. Diabetes is the number one cause of kidney disease, and 35% of all adults with diabetes have kidney disease. The second leading cause of CKD is hypertension and can be a cause and a complication. So you either had hypertension that caused you your kidney disease or your kidney disease caused your hypertension. It's a chicken and egg situation. CKD can also result from smoking, obesity, glomerular disease, autoimmune conditions, AKI, genetic factors like polycystic kidney disease or PKD. Other contributing factors include chronic urinary tract infections, obstructive diseases, age, and certain drugs. The cultural implications of CKD include a higher incidence of kidney failure among certain ethnic groups, such as Hispanics, African Americans, and American Indians, compared to other populations. The characteristics of CKD include a gradual loss of kidney function that occurs before lab abnormalities are detected. Lab changes typically appear before symptoms, which evolve in a predictable sequence. Additionally, the renal size is usually decreased in chronic renal failure. Chronic kidney disease is defined as kidney damage lasting more than 3 months, which may or may not be associated with a decrease in the GFR. This damage can be identified by pathological abnormalities, changes in blood or urine composition, or abnormalities detected in imaging tests. CKD is also characterized by a GFR of less than 60 mLs per minute per 1.73 meters squared for more than 3 months, regardless of the presence or absence of kidney damage. When screening patients for kidney damage, collect data and prevent or delay the progress. The stages of kidney disease are determined by GFR. The majority of patients with CKD are actually in stages 1 and 2, and not all patients progress to stage 5 and dialysis. Stage 1, they're generally asymptomatic. When they progress to stage 2, they could still be asymptomatic, but hypertension develops. In stage 3, they become anemic. You see some bone disease and disorders of calcium, phosphorus, and parathyroid hormone are now manifesting. The patient, though, is still asymptomatic. In stage 4, metabolic acidosis, fatigue, anorexia, edema, impaired memory can now be seen. Your patient is also now hypertensive and have dyslipidemia. Stage 5 is known as ESRD, kidney failure. GFR is now less than 15, and this would require dialysis. Your patient is more symptomatic due to uremia. Uremia is characterized by malaise, weight loss or gain due to fluid retention, neuropathy, trouble sleeping, anorexia, nausea, vomiting, their taste changes, there's edema, they start experiencing muscle cramping, and sometimes cognitive decline. You also note malnutrition due to anorexia or decreased protein intake and or increasing proteinuria. Patients with CKD are at a 10 times greater risk for developing acute kidney injury, especially if they are in stages 1 to 4 of CKD. Acute insults such as sepsis, dehydration, surgery, or age-related factors can cause a rapid decline in kidney function, with the primary treatment goal being to return the patient to their baseline function. The goals of chronic kidney treatment involve in stage 1, you want to diagnose and treat the underlying conditions to slow the disease progression and reduce cardiovascular risk. In stage 2, you want to monitor and estimate the disease progression. When your patient gets to stage 3, you want to identify and treat any complications. In stage 4, prepare for renal replacement therapy, really. And stage 5, you want to initiate renal replacement therapy and manage reversible causes such as heart failure or an acute infection. Focus on preserving kidney function, managing the symptoms, preventing complications, and providing comfort. You want to maintain a blood pressure below 130 over 80 to mitigate the risk to the kidneys. Let's shift our focus on the clinical manifestations of CKD and its nursing management. Refer to this flowchart while studying to help organize your understanding of anatomy and physiology. This is in your book. For diagnosis in CKD, urine studies focus on detecting proteinuria and microalbuminuria, and albumin to creatinine ratio greater than 300 milligrams per 1 gram indicates significant kidney damage. Renal function tests include BUN, creatinine, and electrolyte levels, while measured GFR, different from estimated GFR, which is a blood test, and creatinine clearance are measured through 24-hour urine collection. Imaging via ultrasound identifies structural issues like stones or tumors, and a biopsy provides detailed cellular pathology. The metabolic disturbances in CKD include the accumulation of waste products, resulting in increased BUN, which may cause nausea, vomiting, lethargy, and fatigue because of all that waste products accumulating in your body. And additionally, there can be altered carbohydrate metabolism due to cellular insensitivity to insulin and elevated triglyceride levels. In CKD, electrolyte and acid-base imbalances include sodium fluctuations, which may be normal or low, leading to edema, hypertension, and CHF. There are also disturbances in calcium, phosphate, and magnesium levels, along with metabolic acidosis due to the kidney's inability to excrete acid, primarily ammonia. In chronic renal failure, abnormal labs are expected, and we don't generally freak out at minor abnormals. Your H&H or hemoglobin and hematocrit will be low. Your calcium is low, BUN creatinine elevated, phosphorus is elevated, and potassium is elevated. You should know normal values and expected values in CKD and ESRD. Potassium is a major intercellular electrolyte with 98% found in cells. We could still treat hyperkalemia in the outpatient setting unless it's greater than 6.5. So this is when the patients go on a emergent dialysis and they use put dialysis baths that have significantly lower potassium levels to draw out the potassium from your blood while in dialysis. Hyperkalemia in chronic kidney disease can cause ECG changes, including the disappearance of P waves, widening of the QRS complex, and tall tented T waves. Other symptoms may include muscle weakness, particularly in the lower legs, apathy, confusion, nausea, vomiting, abdominal cramping, and hypoactive bowel sounds. To reduce the risk of hyperkalemia in CKD, it is important to manage diet. So remember to encourage a low sodium, no salt substitute, minimize catabolic states, correct acidosis, for example, with sodium bicarb, and you want to administer blood transfusions during dialysis and monitor medications. The primary goal is to manage hyperkalemia and prevent cardiac arrest. Preventing catabolic states is crucial as cellular destruction releases potassium. Additionally, managing acidosis is key since it can exacerbate hyperkalemia. Here are examples of high potassium foods. Please familiarize yourselves to this list. Your normal calcium level is 8.4 to 10.5. In end-stage renal disease, it is low. So the expected normal for a patient undergoing dialysis would be between 8.4 to 9.5. The imbalance of calcium in chronic kidney disease occurs because the kidneys are unable to convert vitamin D into its active form, which is necessary for calcium absorption. As a result, serum calcium levels drop, leading to hyperparathyroidism and calcium depletion from the bones, potentially causing spontaneous fractures. To manage this, vitamin D analogs like rocaltrol or calcitriol are used to maintain serum calcium levels and suppress parathyroid hormone production. Normal phosphorus is 2.8 to 4.5, but in ESRD expected to be higher. So if your patient is undergoing dialysis and has ESRD, the normal for phosphorus would be around 3.5 to 5.5, ideally less than 6 though. In chronic kidney disease, phosphorus imbalances occurs because the kidneys are unable to excrete excess phosphorus efficiently. So phosphorus is absorbed from a variety of foods in the diet, and because it doesn't dialyze off well, it accumulates in the body, contributing to complications like mineral and bone disorders. Again, a list of high phosphorus foods here. Please familiarize yourselves with this. In chronic kidney disease, hematologic considerations include anemia due to inadequate production of erythropoietin and a decreased lifespan of red blood cells. Additionally, thrombocytopenia can occur, leading to an increased risk of bleeding. Patients with end-stage kidney disease on dialysis often experience chronically low hemoglobin and hematocrit levels. In CKD, acid-base balance is often disturbed, similar to AKI. The kidneys are unable to excrete acids and reabsorb bicarb, right, leading to metabolic acidosis. Over time, the body adjusts to chronic acidosis, so patients may remain asymptomatic. However, bicarbonate supplementation may be necessary if symptoms develop. Please see this chart in your book to learn about assessing for ESRD. The management of chronic kidney disease includes supportive therapy and renal replacement therapies like hemodialysis and peritoneal dialysis. The goal is to alleviate symptoms, manage complications, and support the patient's quality of life. Let's look at medications used in CKD. Medications used to manage anemia in CKD include erythropoietin-stimulating agents like Epogen, Procrit, and Aranesp. As a nurse, you want to be responsible when handling these medications because they are very expensive. Also expect your patient to be on iron supplementation, either oral or intravenous. This includes options like Ferheme or Ferlixit and Vinofer. Phosphate binders in CKD help reduce dietary phosphorus absorption by binding with it in the GI tract. They should be administered with food. Calcium-based binders like calcium carbonate, yes, the Tums that you take, and calcium acetate, FOSLO, are common, though they carry a risk of hypercalcemia. Polymeric phosphate binders such as Renagel or sevelamer hydrochloride are also used. In CKD management, antihypertensives and cardiovascular treatments focus on controlling intravascular volume with antihypertensive medications and diuretics, maintaining dietary sodium restrictions, and addressing heart failure. Medications to avoid in CKD include magnesium-containing antacids or laxatives, fleets enema due to the potential for phosphate overload, and NSAIDs such as aspirin. Nutritional therapy for CKD includes protein restriction, low intake of potassium, sodium, and phosphorus, fluid restriction, and prioritizing calorie intake from carbohydrates and fats. Vitamin supplementation may also be necessary. In CKD stages 1 to 4, protein intake is usually restricted to delay disease progression. However, for patients on dialysis and end-stage renal disease, these protein restrictions are typically relaxed. In older adults with CKD, there is a decrease in kidney size and progressive loss of glomerular function. Additional considerations include reduced function of the loop of Henle and tubules, decreased renal tubule flow due to atherosclerotic changes, increased exposure to nephrotoxic agents, potential prostate enlargement in men, and a higher risk of dehydration. Cultural and ethnic disparities show a higher incidence of CKD in minority populations. African Americans have a significantly higher rate of CKD as a complication of hypertension, with a CKD incidence 4 times greater than that of Caucasians. Native Americans also experience CKD at twice the rate, mainly related to diabetes, with a 6 times greater rate among those with diabetes. End-stage renal disease is a slow and progressive development of renal failure where less than 15% of kidney function remains. At this stage, the kidneys lose their ability to maintain homeostasis, making the condition irreversible and requiring renal replacement therapy to sustain life. Common causes of ESRD or ESKD include diabetes. 41% of all ESRD cases are caused by diabetes. 28% due to hypertension, 11% due to glomerulonephritis, and 3% due to polycystic kidney disease. We talked about uremia earlier. Just to review, it is the term used to describe the symptoms accompanying the buildup of waste in patients with ESRD. It often occurs when the GFR declines to less than 10 ml per hour. Symptoms of uremia are listed here. I've highlighted the symptoms patients often complain about or the common ones I have seen in my practice. When caring for the chronic renal failure patients, the healthcare professional must consider not only the physiological but the psychological impact of the illness on the patient's daily life and that of their family. Dealing with the anticipation that health and well-being may decline over time, and also dealing with the uncertainty of the disease. Medicare ESRD program was established by Congress in 1972 to provide equitable access for all ESRD patients. All ESRD patients are eligible for Medicare regardless of age as long as they have enough work credits. I want to thank you for your attention to this lecture. I hope you have a great rest of your day.